Hello and welcome back everyone. So in this video we will talk about the Laryngotracheobronchitis, which is known as Croup. And Croup is the most common infection of the middle respiratory tract, which is the larynx, the trachea and bronchi in children. And Croup is responsible for most cases of stridor after the neonatal period. And stridor is a high-pitched respiratory sound that is mainly inspiratory, and we will explain it a little bit later in this video. Now, Croup is most prevalent in the fall and early winter, and children aged 6 months to 3 years are most affected, with a peak at an age of 12 to 24 months, and in adolescents, Croup manifests as laryngitis. And Croup could be mild, moderate, or severe, but most cases are mild, benign, and self-limited. Now, the most common cause of this disease is the para-influenza viruses types 1, 2, 3, and 4, and the respiratory syncytial virus RSV. So it is viral in origin. Now, regarding the pathophysiology, so in Croup there is inflammation and swelling of the subglottic area, which interferes with the normal breathing and produces a barking cough, stridor, and hoarse voice. So as you can see here in this picture, so the inflammation would affect the subglottic area right here. There will be inflammation and edema that would lead to narrowing of the trachea here. This narrowing would lead to difficulty breathing and a cough that is described as a barking type of cough, and it would also lead to stridor, which is caused by the turbulent flow of the air through the narrowed trachea, and it would also lead to a hoarse voice. Now, Croup affects children because of small trachea diameter, which means that a small decrease in this diameter due to inflammation and swelling increases the airway resistance and work of breathing. So in children, since the trachea is already narrow, so when there is inflammation and swelling in the trachea, this would exacerbate the narrowing of the trachea, and it would lead to these symptoms. Now, during inspiration, the walls of the subglottic area are drawn together, aggravating the obstruction and producing the stridor. So stridor is a harsh, high-pitched respiratory sound produced by turbulent airflow through the narrowed trachea, and it is usually inspiratory, but it could be biphasic, and it is a sign of upper airway obstruction. Now, we mentioned that Croup could be mild, moderate, or severe. Now, in severe Croup, it's present with signs of upper airway obstruction. Those include significant stridor at rest, and labored breathing means the patient has difficulty breathing, and cyanosis, which is bluish discoloration of skin and mucous membranes, and there is marked suprasternal, intercostal, and subcostal retractions, and there might be wheezing if there is associated lower airway involvement. Now let's talk about the clinical features. So Croup typically begins with a 1 to 3 day prodrome of cough, coryza, inspiratory stridor, and low-grade fever, followed by a 3 to 4 day period of classic barking cough, and in some cases the cough and stridor may have abrupt onset. Now, symptoms peak on day 3 to 4 and are often more severe at night, and physical examination classically shows stridor with a greater inspiratory component. Now, the diagnosis of Croup is clinical by hearing the child coughs, which is a working cough, and by the examination hearing stridor and the low-grade fever. And radiographs are not necessary unless other causes are being considered, and neck or chest radiographs may demonstrate the subglottic narrowing or the steeple sign, which is shown here. As you can see, there is narrowing of the trachea. So this is the trachea here, comes here and narrows. So this is described as the steeple sign. Now, laboratory studies are not useful in diagnosis, but used to exclude more serious differential diagnosis and leukocytosis such as epiglottitis and bacterial tracheitis. Croup doesn't come with leukocytosis. The ones that comes with leukocytosis are epiglottitis and bacterial tracheitis. Now, many PCR tests are available for parainfluenza and RSV viruses to confirm the diagnosis. Now, regarding the differential diagnosis, so it includes epiglottitis, bacterial tracheitis, and parapharyngeal abscess, which will be discussed in separate videos that will come next. And non-infectious differential include foreign body aspiration and laryngomalacia, subglottic stenosis, hemangioma, vascular ring, and vocal cord paralysis. Now let's talk about the treatment. So a patient with significant stridor at rest should be kept in a position of comfort with minimal disturbances, and you monitor the pulse oximetry and provide oxygen as needed. Now, dexamethasone reduces symptoms and need for hospitalization in Croup, and it is administered as a one dose orally or intramuscular, and it is dosed as 0.6 to 1 mg per kilogram, and the IV formulation can be given orally. Now, prednisolone, on the other hand, can be used as an alternative, and it is dosed as 2 mg per kilogram, and it is given in 2 to 3 divided doses. And nebulized budesonide, which is dosed as 2 mg, may also be used. And all of these, the dexamethasone, the prednisolone, and the budesonide, are corticosteroids. So all patients with Croup benefit from corticosteroids, even those with mild symptoms. And the idea is that the corticosteroids decrease the inflammation and edema, and it would decrease the tracheal narrowing. Now also, nebulized racemic epinephrine, which is 2.25%, which is dosed as 0.05 milliliter per kilogram per dose, up to 0.5 milliliters, or nebulized L-epinephrine, which is 1 to 1000, 0.5 milliliter per kilogram per dose, up to 5 milliliters, should be used to treat moderate to severe cases of Croup. And again, moderate to severe cases of Croup present with significant stridor at rest. Now, epinephrine work by reducing the subglottic edema by adrenergic vasoconstriction, and this is temporarily producing marked clinical improvement, and the peak effect is within 10 to 30 minutes, and it fades within 60 to 90 minutes, and a rebound worsening of symptoms may occur. So epinephrine need to be repeated every 20 minutes for no more than 2 hours in severe cases. And epinephrine decreases intubation rates, so it has a very significant effect. Now, children with persistent stridor at rest, which also have tachypnea, retractions, or hypoxia, or those who require more than 2 treatments of epinephrine, should be admitted to the hospital. Now, prognosis of Croup is excellent, and illness lasts for 5 days, and most common complication is viral pneumonia, which occur in 1% of Croup cases, and secondary bacterial tracheitis is very rare complication and occur in immunocompromised patients. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And you can support more by joining the channel. Link will be in the description of this video.